Good evening from New York. I'm Selwyn Collins, your host of CWS Journeys. Thank you for joining us this evening. My guest this evening is Dr. Oneeka Williams, who is no stranger to CWS. But I'm especially glad to have her here this evening because we have been trying for some time now to get her to find a suitable time for her to appear because of the topic tonight: cancer, prostate cancer in the Caribbean. We are back with the lovely Dr. Oneeka Williams. Dr. Williams, good evening.
Good evening, Selwyn.
And welcome again.
Thank you.
Dr. Oneeka Williams is a Harvard Medical School graduate who ranks among the top urologic surgeons in the United States. A native of the Caribbean, she was born and raised in Guyana, South America, and moved with her family to Barbados at the age of 10, where she attended Christ Church Foundation School and Harrison College. From an early age, her science teacher, mother, and journalist father instilled in her a love for the sciences and writing. Dr. Williams, tonight is a conversation with a little difference because you've been on here before and we've gone through your whole biography and so on. So I want to focus our time on the topic, which is prostate cancer in the Caribbean. But before we get into it, tell us what made you decide to specialize in urology?
So there were a number of things that led me to urology. I would say the very first and foremost, when I started medical school and we went through our clinical rotations, that's an opportunity for us to identify what are the things that appeal to us, what are the subject areas that we find interesting, and what patient population tends to really pique our interest in terms of wanting to be engaged in the primary medical intervention management. And it became clear to me that I would be a surgeon. I wanted to be a surgeon. As I went through my clinical rotations, the minute I got into the operating room, I felt an instant affinity. I felt an instant love. I loved it.
I don't, I don't know if it's me, but your volume seemed a little low, just a little.
Can you hear me any better?
Okay, oh yes, that's much better. Wow. Sorry about that. Sorry about that. Okay.
And I identified once I got into the operating room that that's what I really enjoyed approaching. I enjoyed approaching, medical interventions with my hand. I enjoyed the opportunity to identify a problem and then deal with it in a speedy fashion. And
hold on a second, Oneeka. Just hold on. Let me try and see if I can get rid of this. I don't know why this is happening. Go ahead. Go ahead.
So I love being in the operating room. I love the surgical way of thinking about things. I love the surgical way of approaching things. And so once I had identified that surgery was my true love, what I then had to establish was what specialty in surgery did I want to be involved in, to train in. And this obviously, had to do with, different types of subject areas. Did I like ear, nose, and throat? Did I like cardiac surgery? Maybe the subjects were of interest. What type of patient populations would I serve? And then, thinking about the lifestyle that I want to be a trauma surgeon, where I was up at all hours of the night, sort of life and death type of situations. And so those are all considerations that I entertained and explored when I was deciding about what surgeon specialty I wanted to enter. And then I had an experience at the West Roxbury VA where I was shadowing one of the residents in multiple various outpatient clinics. And one of the residents that I was assigned to was a urology resident. And I had not given much thought, I have to admit, to urology as a surgeon specialty, as a specialty where there are very few women. So I didn't have an automatic sort of affinity or interest. So, or even much knowledge about what it really involved and entailed. So I followed this resident around, and the very first patient that we saw was an elderly man who had been, unfortunately, he had experienced what we call the sort of flesh-eating bacteria of the scrotal skin. And his infection was so severe that in order to save his life, it was necessary to remove all of his scrotal skin. And what that then left were his testicles, which had sort of nowhere to go. and they were surgically placed into his inner thigh, into pouches that were made in his inner thigh by the urologists and the urologic surgeons. And when he came back to clinic, I saw him on the tail end of this, which was like he had the surgery, he had recovered from the infection, and then it was necessary to then recreate scrotal pouches for him and to replace his testicles from the inner thigh back into his newly reconstructed scrotum. And I just found that to be the most interesting and fascinating. You know, his process, the way in which he had been managed, the surgery, the subject matter. I was just enthralled, and that was my, bit of introduction to urology, and it made such an impact that I almost immediately decided that this is what I wanted to do, and thus became this became my involvement with urology. I have to say that there were a number of other things that I found to be particularly appealing once I got more involved and understood what was involved in the specialty. I love that there are multiple ways to intervene, that it's not just a surgical specialty in terms of, operating on everyone in an open fashion. There are many types of endoscopic, minimally invasive techniques that are available. It's a type of specialty where you establish and continue and maintain relationships with your patients, ongoing relationships. And so one of the things that I really value about medicine and the practice of medicine is the patient-doctor interaction, where I am not only a surgeon where I'm operating on them or a practitioner where I'm prescribing medications, but I'm developing relationships where they build trust in me. I get to know them. I get to know their families. I get to be actively involved in their medical care for many years. And this is the type of interaction that I really enjoy. So urology allows for that type of long-term relationships with patients. You're not just a technician where you operate and then you send the patient back to where he came from. You are responsible for their sort of urologic health in terms of whatever it is that you're managing for many years to come. I also love the flexibility and the diversity of the patients that we see. I can do cancer, I can do stone, I can do reconstructive surgery, I can do pediatric urology, I can do females, I can do male, erectile dysfunction, infertility. There are so many areas that I have the ability to be constantly engaged with patients, and as such, it just allows for a breadth of constant new learning, constant new ways of thinking about the different patients to think about, to work with. So overall, it's just a very enjoyable specialty, and as you can imagine, as a woman in urology, there are many stories that I can tell that are very interesting in terms of my day-to-day, the things that I encounter.
Can you give us a brief introduction to prostate cancer?
So let's talk a little bit just about what the prostate is. So the prostate is a walnut-shaped gland that is located just at the base of the bladder. And essentially, it is the tube that connects the bladder and runs through the penis, which is called the urethra, that allows the bladder to empty the urine into the external environment. The prostate surrounds that urethra, what we call the urethra, at the base of the bladder. And the purpose of the prostate is essentially to really support the sperm. It produces fluid that protects and supports the sperm so that they can be healthy and do what they're supposed to do. And the prostate is made up of both muscles and glands. And those glands produce the fluid I described, and the muscles are responsible for creating this rhythmic contraction during ejaculation, which propels the fluid into the seminal, into the urethra, and to bring it into contact with the sperm, which is then delivered from the testicles in order to provide the fluid for the ejaculate. And there are a number of disease processes and processes that affect the prostate. And in three large categories, there are prostatic enlargement, which begins at age 35 and becomes much more evident as men age. There is prostatic inflammation, which we more commonly call prostatitis. So this could be both bacterial, where there are clearly infectious agents, or can be a chronic inflammatory process that creates prostatic symptoms like chronic pain, frequency and urgency, and so on. And then there's prostate cancer. And prostate cancer is the malignant transformation of prostatic cells, which, interestingly enough, seems to be almost a natural transformation that happens within the prostate as men age. And we don't understand why prostatic cells will eventually undergo malignant transformation. But what we can say is that if we biopsy men over the age of 80, probably 75 to 80% of those men will have prostate cancer cells within the prostate. And so within that malignant transformation that happens just based on the aging of the prostate, we then know that many men within their lifetime will be affected with by prostate cancer cells. So the question then becomes, as we think about prostate cancer, and we know that most men within their lifetime, if you were to biopsy the prostate, will have prostate cancer cells, is how do we then identify which of those prostate cancers are going to be clinically significant and which of those are not? And so does that answer your question?
Yes, it certainly does. And I mean, is there a way of preventing that from happening?
So there really is not a way, as far as we know, to prevent prostate cancer. There are a number of things that are being explored in one of those things, thinking about, can there be a vaccine developed against prostate cancer? But at this time, there is no way to prevent prostate cancer. What we can do is identify those risk factors that either seem to increase the likelihood that you might be affected adversely by prostate cancer, or two, to identify those people who are at higher risk. And so we know that there are certain things that we think are contributors to prostate cancer. One, developing prostate cancer. One is high-fat diet. Certainly one is age. We've talked about that already. One is obesity and high-fat diet. I think that there's a relationship between diet and prostate cancer. Three is there is definitely a genetic predisposition, and there are ethnic groups that are more likely to develop prostate cancers. We know that African Americans are, or people of African descent, men of African descent are 1.6 to 2 times as likely to develop prostate cancer, and then unfortunately 2.5 times as likely to die from prostate cancer. So we see that as a high risk group. Additionally, if you have a family history, in other words, if you have a first degree relative, a brother or a father with prostate cancer, you're 2.5 times as likely to develop prostate cancer. So those are, some of the things that we identify as increasing the risk of developing prostate cancer. So we know age is certainly a huge predictor.
That brings me to my next question. Why is a conversation on prostate cancer in the Caribbean so important?
Well, the conversation about prostate cancer in the Caribbean is very important because we know, and we've seen, and I have a number of graphs that we can actually show a couple of those now. If you would pull up graph number 3.
That's the one with
cancer by incidence and mortality rate.
13% or?
This is by country, 2002 by country.
Oh, okay, hold on.
So not the pie chart, not the bar chart, the horizontal.
Gotcha. I gotcha.
If you look at the horizontal chart.
Yeah. Mm-hmm.
What that's showing us is that this was a study just released by PAHO and the World Health Organization in 2013. And what it identified, I don't see it up as yet, but what it identified is that when we look at prostate cancer by incidence, meaning the countries that have the highest rates of prostate cancer, we identified that Martinique, Trinidad and Tobago, Barbados, Jamaica, Guyana, all featured very prominently among the top 10 of countries that have the highest incidence of prostate cancer. And then if we look at the mortality rate, so in other words, of those patients who are diagnosed with prostate cancer, what is the rate of men dying from prostate cancer? And Trinidad and Tobago has the highest mortality rate from prostate cancer. And that is followed by Guyana, Barbados, Jamaica, Martinique, Guadeloupe, Nicaragua, Chile, Latin America are all represented. But Trinidad and Tobago, Barbados have among the highest mortality rates in the world. And so that's extremely concerning. And so it brings us into direct realization that there is a significant problem, that there is significant need to address where the genesis of these issues are and how do we, one, accumulate the data and how do we identify what are some of the interventions, what are some of the considerations, what are some of the tools that we need to use in order to address what is, I think, a very, very, very
My question is this: Guyana, how is it possible that Guyana has probably the smallest population among the countries identified, yet it is right up there on the Trinidad?
Right. So the issue is not so much the population, but the issue is certainly what we call the rate. So if we look for 100,000, how many men are being diagnosed with prostate cancer? And of those men that are diagnosed with prostate cancer, how many of those will die? So if we look at Trinidad and Tobago, and for every 100,000 men, there are, the mortality rate is going to be about, about 200, well, the incidence is going to be about 220 of those of men are going to be diagnosed with prostate cancer. And then of those, the highest rate of the number of men dying per 100,000 is represented within some of those Caribbean territories. So the population doesn't really so much matter. What certainly matters and what we've identified is that there's clearly, as I mentioned before, at least twice, double the risk of prostate cancer in men of African descent. And so when we look at countries, for instance, even if we take Tobago, we take Guyana, we take Jamaica, and we look at the percentage of the population that are Black men, then because of the higher population of men of African descent, increases the incidence of prostate cancer just because of this, what we think is, maybe some type of genetic predisposition based on being of African descent, even though we have not identified that at this time. Because there is a higher risk in men of African descent, countries that have a higher representation of men of African descent will then by just,
And then that same report, I believe, mentioned that Canada and the US have higher incidence, yet their mortality is not
precise.
as high.
So the incidence in Canada and the US are higher if we look at the number of men per 100,000 that are actually diagnosed. In Canada, for every 9 men that is diagnosed with prostate cancer, only one of those 9 men will die. If we look at a country like Haiti, for every 2 men that are diagnosed with prostate cancer, 1 of those will die. So that's a very significant difference, and it really then brings us into a discussion about why is that.
I see. John in the chat room asks, what is the leading cause of prostate cancer?
What is the leading cause of prostate
Yes.
cancer? Well, once again, we don't have a great answer for that in terms of why the prostate undergoes malignant transformation as men get older. I mean, it is a natural aging of the prostate. And we know that one of the things when we think about why do people get cancer, why do cells begin to behave abnormally, we think that there's a huge relationship, or it has been demonstrated that the science of malignant transformation has to do with damage to DNA, it has to do with oncogenes turning on and off, with the genes that protect us from malignant transformations, from cells going haywire, are all encoded, and whether there's some relationship to our environment, we become more and more exposed to agents that are causing our bodies to break down and the cells and the DNA structures within our bodies to be affected in such a way that the cells begin to divide in a normal fashion. The prostate may be more susceptible to that for reasons that we don't necessarily understand. There have been some definite genes that have been identified where patients or for who have those genes, for instance, we know the BRCA gene 1 and 2, for women who have that gene, who express that gene, are at higher risk of developing breast cancer. And we know that men who express that gene are at a higher risk of developing prostate cancer. Within those gene pools, however, within those, what we call sort of those abnormalities within those mutations within the genes, only about 2% currently, in terms of the studies that have been done, only about 2% of men with prostate cancer actually have those gene mutations that have been identified in
Wow.
studies. So that we haven't been able to say, well, here is the gene mutation, and this is the reason that men are developing prostate cancer. It is just a natural transformation within the prostate, and we don't understand the biology completely.
What is the most frequently asked question by men about prostate cancer?
So I would say the most frequently asked question about from men is is this something that really needs to be treated? And it's a very good question because that is part and parcel of much of the dilemma about prostate cancer screening. Who gets treated for prostate cancer? What are the criteria and the factors that determine, number one, whether you should be screened, number two, who should be treated? And this has been a big public debate within the US within the last several years, to the extent that the United States Preventative Services Task Force came up with a recommendation about 2 years ago that men should not routinely, at least within the US, be screened for prostate cancer. And part of the concern was, that there was, number one, as we talked about, that there are the subset of men, if we check prostates and we biopsy all the prostates and we identify those prostate cancer cells, the subset of men for whom those cancers are actually going to be clinically relevant and significant is actually very low. And so by over-diagnosing, meaning that you're doing prostate cancer is usually diagnosed, at least screened by PSA, which is a prostate-specific antigen, which is a chemical or substance that's made within the prostate that becomes elevated in the settings of prostate cancer, but can also be elevated for a number of other reasons. So elevation of the PSA and a digital rectal exam, which is a rectal exam that the way the prostate can be palpated, are the two methods that we currently have of screening for prostate cancer. And so the problem is that for people who have an elevation of their PSAs, it's not necessarily specific for a diagnosis of prostate cancer. And even if that patient is diagnosed with prostate cancer, it's not necessarily going to affect their lifetime. So the concern is about overdiagnosing, over-treating, and even something as simple as doing what follows next if you have an abnormal rectal exam and an abnormal PSA is a prostate biopsy, which in itself has a number of potential risks and complications that can adversely affect patients. And so, how do you identify those men whose prostate cancers are actually going to create a problem for them? So within the US, routine screening for prostate cancer as a broad, kind of identification of early diagnosis of prostate cancer has felt to have created a set of circumstances where people are being overdiagnosed. Within the Caribbean, however, I think there is a different scenario because even within this country, screening is still recommended for men who we identify are at high risk. And so within certain populations, such as men, African American or men of African descent, we know that they're twice as likely to develop prostate cancer. They're 2.5 times as likely to die from prostate cancer. They're more likely to be diagnosed at an early age, so they're earlier presenting with prostate cancer, even though we think of prostate cancer as a disease of older men. 75% of men who are diagnosed with prostate cancer are over the age of 70. But in men of African descent, they're diagnosed earlier, their tumors are diagnosed when they're larger, and they present with more advanced disease. And so because of that population that has such higher risk of developing prostate cancer, and prostate cancer that has more adverse outcomes, the recommendation is certainly that screening for those populations should be done. And so that really takes us back to the Caribbean, because
Right.
as we are dealing with a population that is more has a higher risk of developing prostate cancer, then the conversation is about that is a population that should be screened. And one of the